My name's Dione.
And my name's Rayna.
Today we will be talking about substance use disorders.
And really just having a conversation about how substance use disorders impact women and how that's relevant towards feminist theory. So I guess I can start just giving the audience some basic facts about substance use disorder. Substance use disorder is just uncontrolled use of a substance despite its harmful consequences. That's the definition coming from the American Psychiatric Association. I think one of the most important things to know about it is that it is just generally addiction to a substance. We normally will sometimes hear things like addiction or being an addict. That is not the actual problem. The problem is that you keep using a substance even when it hurts you.
About 27.2 million Americans 12 or older reported battling a drug use disorder in the past year, according to the American Addiction Center.
Yeah, and about 10.2% of Americans 12 and older had specifically an alcohol use disorder in the past year.
And in 2020, 8.6 million women and girls aged 12 and up misuse psychotherapeutic drugs like sedatives, stimulants, and pain relievers.
I thought that was a super interesting fact too, because basically the way that they measure that is if you're using it in a way that's not prescribed to you. So for so many women, 8.6 million women in the US, 12 and older are utilizing sedatives and stimulants and pain relievers. One thing that reminded me of is those drugs give using them for self-medication. You don't use pain relievers to get high, they're used for pain relief. So things like that being particularly related to women, I thought was super interesting.
It kind of makes me wonder if that's because the medical system and the healthcare system doesn't really help women. Do you know what I mean?
Yeah.
Especially with pain. Because I know for period pain and period cramps, they have these pain relievers that are called what is it? Do you know what I'm talking about? The PMS relief stuff?
Yes.
But those don't usually work. So a lot of people, I know a couple of my friends are whenever I'm on my period, I take 4 Advils every hour. And I'm that's
Me
not
too.
really healthy.
Well, we were just actually talking about this because I have a migraine right now, and we were talking about Excedrin, and this migraine that I have, it's normally my last day after my period, I'll get a migraine. It's a drop in estrogen, so you normally get a migraine at this time, and I'm about to take 2 Excedrin, and then I'll take 2 more at 7 if it doesn't go away. So yeah, that's super relevant.
No, wait, me too.
The pain management is crazy. It also made me think of birth control, and I was researching copper IUDs. A lot of women are they don't provide any kind of pain relief for the insertion of a copper IUD, which literally goes into your cervix.
No, yeah, that's a really big problem, especially because I'm interested in women's healthcare, where I know a lot of women would be I have gone an IUD and they just told me to take Advil after or before their procedure. And since it is a medical procedure, you would think that they would, I don't know, use anesthesia or something. I don't know, I feel a lot of healthcare providers just simply don't care about women's pain.
Especially when you compare it to, I've had someone in my life recently get a vasectomy because of recent political events, which good for you, King. And they put him on bed rest for a week. They prescribed him a non-steroidal anti-inflammatory drug like ibuprofen, but it was a much stronger version of it, and they gave him a month's supply for this procedure. But when you get a copper IUD inserted into your cervix, you don't get that at all.
Wow, that's actually kind of crazy.
I was very surprised when he was telling me about it, especially from what I know about things like pap smears too.
Yeah.
This reminds me a lot about pain management for Black women and how they're uniquely impacted by that.
Yeah, so in regards to what we've discussed in class, with pain management, you can really see the disparities within race and class and gender, obviously because we're talking about women. But a lot of pain management does have to do with intersectionality, and it is known that a lot of Black women's pain is ignored in the medical setting, especially when Black women are giving birth. We can see that with the high maternal mortality rates with Black women and infant mortality rates.
Yeah, that reminded me of this quote I read in a different book by Bell Hooks. It's called Sisters of the Yam, and it's about like recovery and rest as a black woman, and basically, like, to paraphrase part of one of her conclusions that she makes in the first chapter is like, black women assume the myth of being a strong black woman, and they kind of expect themselves to be like this goddess who has like built-in capacities to deal with hardships without breaking down. So not only is there like this disregarding of their pain in the medical system, but they are also socialized to like deal with their pain privately, which can obviously lead to like misuse of different substances.
I feel like that's why a lot of black women have a hard time going to the doctor. I know a lot of my friends who are black, yeah, they're feeling sick, they'll just like take a bunch of like Advil, Tylenol, and like hope the issues fix themselves, but they don't really like seek out medical care, like ever. And I could say that for myself either. Like, I hate going to the doctor. I've had such bad experiences. I like literally had like my health like disregarded just because, you know, it's a medical system. I usually just like resort to Advil, which is not good. But
yeah, I definitely relate. I think most of my experiences, like when I go to the doctor, they have been about like, how do I communicate like how serious this problem that I'm having is. Like when I decide to go to the doctor, normally they'll be like, oh, well, how long have you been having this problem? And it feels like kind of invalidating. Like, I've been having it long enough that I felt like I need to go see a professional.
A lot of like low-income black women have heroin use disorder. That community, because they are low income, and black and a woman, they have all these like intersectional identities that kind of like marginalize them. But they use like heroin to kind of like, you know, make themselves like feel better and like not really worry about their issues. I know that's like a really big like public health thing where they don't really know like how to help these women or like kind of how to like fix this issue. Do you have any thoughts about that?
Yeah, I've heard of locally and in other places as well, I've heard of needle exchange programs where they will give you free sterile needles for use, because that is like an unintended consequence of heroin use disorder in low income areas, is like you will just share a needle because you have to buy the needle, so it can spread like different illnesses like that. I also know in other countries, like specifically in Sweden, they've started doing government funded use rooms. So there they provide needles, kind of this conversation of like, people are going to be using these substances anyway. We don't want them to like freeze to death in the winter while they're doing this, or contract a disease from like a needle. Substance use disorder is heavily decriminalized in Sweden, and so it's like more of a public health thing.
Oh, that's a really interesting point. I've never heard about countries doing that or programs doing that, but I feel like that should be implemented in the United States.
Yeah, hopefully one day. This was such a great conversation, Dione.
It was great talking to you, Rayna.
Hi, I'm Skylar.
I'm Zoe.
I'm Grace. And we are Women and Gender Studies students. And today we are going to be discussing women's healthcare in the United States, starting with how women's pain is perceived. So what are y'all's experiences with this?
I have not personally experienced, but have heard the pain that comes with IUD and labor and birth.
But it's really not just reproductive care either, is it? It's going in for sepsis, it's going in for a broken arm, it's going in for anything that can't be seen directly and being dismissed from healthcare providers.
Even starting from a young age, little girls will be dismissed right away in the hospital from teachers, from any adult, that their problems or pain is nothing.
I agree. I think the first thing you think of with pain, of being a woman, and like the dismissives of pain is like things such as childbirth and an IUD, but it really goes so much deeper than that.
It's really a systematic problem just outside what is considered blanket women's health care. It is factual that men receive more medication for the same pain scale rating as women do. Physicians are more likely to prescribe men these medications, more likely to take them seriously about the same conditions. And if we're talking just women's health care and reproductive health care in general, let's talk about IUD insertions. Just to give a person an idea of what an IUD insertion entails, the cervix is clamped with what looks like needles. It is punctured, spread open, and something is inserted into the uterus through the cervix. And this can come with a variety of pain. In a study which rated pain from patients and the perceived pain from physicians, patients rated their maximum level of pain from IUD insertion as 64.8 mm on a 100 mm visual analog scale, while providers perceived their patient's pain to be 35.3 mm out of 100 mm. So what's the disconnect? Why is this happening?
Like, why is the perception so much lower than the actual
rating? Yeah. So why is women's pain not taken seriously? Let's link it back to systematic violence, that women are expected to endure this pain and therefore endure it better.
There's a quote from Bell Hooks. I believe that violence is inextricably linked to all acts of violence in this society that occur between the powerful and the powerless, the dominant and the dominated.
This power structure is provider woman, provider men ranked over woman, authority over woman. Because women have been historically and socially subjected to violence for so long that it has become normalized. That violence in the form of pain mismanagement is so rooted in our healthcare system that there has been little progress. The treatment for IUD insertion or management is Aleve, over the counter. Linking that back to everything else, physicians feel it is less responsibility to manage a woman's pain because of this systematic violence, which has normalized it.
I think such an interesting point of that quote, the concept of the dominator versus the dominated. And why is it that the person who's dominated is being subjected but somehow receiving less pain medication?
Yes. Because if you think about it, IUDs can be used to manage a variety of symptoms such as painful menstruation, but a main purpose of it is birth control. Women don't want to be pregnant, so they subject themselves to pain to take control of their lives.
Going off the topic of birth control, there's kind of a new concept that has come out within the last year, really, and that's called the O pill, which is an over-the-counter birth control pill that you can buy at major stores such as Walmart, Walgreens, and CVS. And it first became available in the United States on March 4th, 2024, but had previously been approved by the FDA in July 2023. So what do we think about this concept of something that we can just go and buy in a store?
I think this is a revolutionary product because it helps alleviate the gap between those who can access and can't access OBGYN or doctors, private providers for their own prescribed birth control versus going to over-the-counter where they can just go by themselves and without having to have insurance or a doctor's note.
That's true. That's definitely a pro of this. But we also have to remember that pill birth control is hormonal therapy and it will cause side effects. And so how educated are women going into this?
That brings up kind of the next point that I was thinking about, how when you go to the doctor, there's tons of different pills that you can get and you can kind of try different ones. It's like a shoe fit scenario. Like one birth control isn't going to work the way it works for one person versus another person. Like what do we think about this kind of like one size fits all, I guess, approach of this pill?
I think like what Grace was saying, it is revolutionary and progressive and definitely what we need, but it's still not the solution. Birth control, if you're using it for preventing contraception, then it is still the woman's problem. We have condoms, we don't have anything else for men besides spermicides. There are currently 11 different hormonal birth control available to women and not a single one to men. So women are the only ones suffering physiological side effects from contraceptive methods, while men just get to buy something to put on or use in the moment.
Mm-hmm. And that reminds me of a quote on page 145 of Margaret Sanger's Birth Control, A Parent's Problem or from Women in the New Race. It reads, "Women must have her freedom, the fundamental freedom for choosing whether or not she shall be a mother and how many children she will have."
So we're talking about birth control for men too, as a side note of that. Birth control for men, condoms, spermicides, those are only effective during consensual sex. If a woman truly wants to prevent and take control of the autonomy of her life, then birth control is almost necessary.
Along with birth control, another necessary is sex education.
Oh yeah. I grew up partially in New Mexico and partially in Georgia, and my experiences with sex education differed greatly between the region of the United States I was taught in.
I grew up in Connecticut, and then I came to school in Georgia, and it's just been really interesting to hear like my experience of sex education versus coming down here and hearing about everybody else's.
Yeah, I grew up in Texas where there's virtually no sex education, and I was really surprised when I learned that other states provided sex education during their school years.
You know what's interesting to me? This isn't fully federally regulated. And while the government supports certain guidelines and promotes sex education in all states, it's ultimately left up to the state. But another thing is that the government partners with abstinence only until marriage sex education providers. They receive about $35 million in funding annually. They received a deal in 2016, which increased funding to $85 million per year in fiscal year 2016. That is still in effect today.
That's so crazy.
So is abstinence only sex education effective? What are people getting out of this?
I think it's interesting that like I'm just now hearing about this program.
Yeah.
Like I had no idea this funding was even there. I don't know, I feel like sex ed, especially like the real concept of it is like so like let's just get through it kind of thing.
Yeah.
We're not there at all.
Yeah, not at all in some states, especially the southern states. And even in Georgia, sex education is not aligned with national sex education standards, so it's really just up to the schools or the county and states about what they want to teach.
Mm-hmm. And taking into account social stigma or cultural factors, certain people in populations and demographics aren't as likely as other privileged ones with access to technology, healthcare providers, to learn about their own bodies. And the majority of the population is going to engage in sex as a natural human activity. That's something that provides benefits outside of conception. It provides physical, mental, interpersonal relationship benefits that so many people are likely to engage in. So why does the government have these tools to teach women and men about contraception and about choosing these decisions for themselves, but chooses to withhold that information?
Like if it's something that you know that's gonna happen, why aren't we just gonna talk about it?
Yeah, especially when we now have over-the-counter birth control.
Yeah, just another way for the government to control women and oppress women.
So going back to the systems of violence, I do think it is a violent act for the government to knowingly withhold information from youth and developing adults about how to take control of their lives.
Especially when there is so many pill, IUD, birth controls that like go into play beyond that.
Yeah.
It's the 21st century and we're still lacking on so much. These are 3 different avenues where the government subjugates women's healthcare and reproductive health.
And when you really look at and analyze the way the government approaches pain management, birth control, and sex education in this country, we can really relate it back to what ryoo stated, that the essence of woman is to get fucked by men.
Hi guys, I'm Olivia.
I'm Lexiana.
And welcome to our podcast.
Welcome.
Today we're going to be talking about women in healthcare, specifically in the workplace. So not just how women are affected in healthcare systems like we talk about in some of the other episodes,
Right.
but specifically how women who are working in the healthcare system are impacted as women.
We're gonna go through a few topics,
Yeah.
but the first one we're kind of gonna go about is pay gaps specifically in healthcare,
Yeah.
noting that they're everywhere, and then how that kind of ties into underrepresentation in leadership.
I feel like there are some general issues with that kind of apply to any workplace scenario that I don't want to dismiss in healthcare. One of those, like Lexiana said, is definitely pay gaps. Women in healthcare often earn less than men for the exact same roles. One of my sources that I found said that on average 25% how much less they're making than men in similar roles. That's obviously a lot. Making 25% less, I mean, the pay gap is pretty much applicable to any other roles. That obviously also contributes to like the general systemic inequalities, and it's also a consequence of those systemic inequalities, which also relates to the underrepresentation in leadership. So women make up the majority of the healthcare workforce. They are like a lot of the nurses, a lot of the social workers, and the child life specialists, and the support staff, and the therapists, and all that stuff. But they tend to be neglected in leadership roles, especially in high-paying specialties like surgery and cardiology, which is concerning.
I think it's really interesting because my mom is in leadership at a hospital.
Really?
She's the director of the operating room.
Oh, wow.
So she is like the person who oversees there's like 16 ORs at her hospital. And she's had people who are above her get hired, and it'll be a man, and he has absolutely no background in healthcare whatsoever. But like, she's a nurse, but typically it's funny because this isn't the first time it's happened. Her boss is a man, and has literally like not saying that you can't do something you don't have a degree in, but when there are women under you that are more qualified, have worked as a nurse, have worked as an OR nurse, it is honestly truly surprising. So I think that in my head is something that maybe probably contributes to it, because if you have all of these degrees, like my mom went back to school and got her master's degree, like if there's all of this work that you need to put in to get into a position that you aren't even going to be paid as much as if a man got it for half less of the work, like what's the point of doing it? So I feel like that probably contributes to it as well. Also, people just not hiring women in general.
And I feel like the underrepresentation of women in leadership is pretty consistent throughout a lot of workplace demographics.
Even unfortunately, in places that are stereotypically women women jobs, like teaching or
like the principal will be a man. And I feel like, so we're recording this on November 7th. The election was 2 days ago. This all feels very sensitive right now in terms of how women are being neglected in leadership, because you said like, oh my gosh, talking about qualified women. I wasn't even thinking about that. No, like you were literally describing it. You were like, wow, like a totally qualified woman is being neglected a job opportunity, and it's handed to a man with none of the background that she qualifies for and has. That's why I feel like this is kind of like a smaller scale example where those same like feminist activism ideologies still apply. The idea of like sisterhood and unity that we've seen in so much feminist literature, like that stands true in politics, it stands true in your friend group, it also stands true in healthcare. That is the same, and it requires just as much attention. So those women are suffering the same consequences as many other women, the pay gaps and the underrepresentation. But specifically in healthcare, I read that mental health and burnout has been worse for women in healthcare with the COVID-19 pandemic, but not entirely. Female professionals are significantly more likely to burn out, and they have higher burnout rates due to things like emotional labor of caregiving and their gendered expectations. So a female nurse might be more expected to be super involved with the family and be really emotionally connected to them, where a male might not be. Studies show that female healthcare workers report higher levels of burnout and stress compared to their male peers, particularly during the COVID-19 pandemic. I think a lot was expected of them.
Yes, it was definitely heightened.
Right, which also leads into the patient-centered care aspect. These women are expected to serve their patients in a certain way that can put a lot of emotional stress. And as someone who wants to go into child life, where like a lot of the job is helping families cope and process and like deal with grief and anticipatory grief, I've learned about like how to set boundaries and how to not get too over emotionally involved. But everyone who I've talked to about that has said that it's also inevitable.
Right.
You can only avoid that to a certain extent. I'm sure, like, that's not to say that men don't have those same emotional like qualms and stuff, but in my experience, I've never heard men talk about it. And that could have to do with male stereotypes of like not being emotional and stuff, but like I've never heard in all my classes that are pretty healthcare focused, I've never had a man come and talk about his emotional burnout.
Oh, for sure.
You know?
Yeah. I think I do agree with you that it's probably has to do with the fact that like men are so conditioned not to speak about their emotions.
Right.
And I can tell the difference, like, for context, everyone in class knows I work at a hospital. But
yes.
For the
general pop.
For the gen pop, I work at a hospital and I work directly with doctors. Mind you, there's only one female doctor in this group.
Really?
Yes.
In the whole ER?
Yeah.
Wow.
It is kind of stark, like you can tell the difference between like how the nurse kind of talks to the patient and how like the doctor can kind of sometimes talk to the patient, like the difference and it could be because like, nurses have more of a hand in direct patient care than physicians do, but I can't help but contribute to the fact that most of the doctors are male. I also think the burnout, you could see it more in COVID-19 because COVID-19 was absolutely horrible for everyone and just there are so
especially
many,
in healthcare.
Exactly, there are so many things, but like before that, like I think the main contributing factor is like the culture of the workplace.
Yeah.
And like the expectations of on women to be like that maternal figure in the room and like comfort these people. Like that shouldn't have to be your job.
Yeah.
Like realistically, you want to be an empathetic person. It's like they teach you how to be empathetic in medical school. Like they literally like make you go through like simulations. But like that shouldn't have to be put on like a nurse just because like they're expected to be.
Right.
And then like especially like if we're gonna focus on physicians in terms of burnout, like having to be in a like locker room talk, like that is so real. Oh my god, it's so real.
Interesting.
Like I think it's a stereotype of doctors that like they have an ego and like all this stuff. And, like obviously some people do really play into that. Yeah. But it's so detrimental to her entire mental health. Is like you have to go to work each day, your work sucks, your schedule sucks, and then you have to deal with men like doubting your like everything.
Your capabilities.
Exactly.
Yeah, and that
I feel like goes into
pretty much streamlines us into like so additionally, studies have shown that female physicians are more likely to engage in patient-centered care and emphasizing empathy, communication, and shared decision-making with patients. This also correlates a higher percentage of female doctors going into fields like pediatrics and becoming like OBGYNs. Specialties with fewer women, like neurosurgery, show less engagement with patient-centered care. So that directly correlates to where their burnout could be coming from. I think part of that, my thinking is like, okay, well, why aren't they teaching that kind of empathy and patient-centered care, family-centered care in the curriculum and in the courses in med school and in undergrad and all that stuff? But also, like, now that I'm thinking about it, it really also could just be a from birth thing.
I was gonna say it's almost like it's innate.
Right.
It is innate. Like we all know.
Well, it's like socialized.
Like that maternal,
right.
For sure.
Right.
Yes, definitely.
To me, it almost seems obvious that, like, okay, a qualification of a physician, of a surgeon, should be, like, empathy. Like, you should have that automatically in order to be in that position, but obviously, like, that's not how our workforce works in America. That's not, like, gonna be a checkbox for anyone. Policies, the maternity leave, flexible working conditions, anti-discrimination laws, all that stuff disproportionately affects women. Feminist advocacy in healthcare often pushes for these policy changes and to encourage women's work-life balance and protecting against gender-based discrimination. I feel like talking about this in terms of feminism and feminist theory, it was very much giving bell hooks to me. Because she talks a lot about work, and while she doesn't, talk specifically about healthcare, but she does say, to build a mass-based feminist movement, we need to have a liberatory ideology that can be shared with everyone. That revolutionary ideology can be created only if the experiences of people on the margin who suffer sexist oppression and other forms of group oppression are understood, addressed, and incorporated. They must participate in feminist movement as makers of theory and as leaders of action. I think the importance of community and staying passionate about what you're passionate about and not giving up when hope feels few and far between is really important.
I agree, because that's how, not to give it a ominous they, but that's how they win. If all of us give up.
You're completely right. And like being angry works.
But you gotta do something about it. You gotta do something with it.
I completely agree.
Yeah.
Well, thanks so much for listening to our podcast,
Thanks
guys.
for listening to us talk,
Hope you enjoyed. Hope it wasn't too sad. Thanks for listening.
Bye, guys.
Bye.